Hello everyone, this is Chadi Alraies from ARCH 2023. I'm really privileged today to be with Dr. Alpesh Shah from Methodist, and he gave a phenomenal talk about approach and management of severely calcified lesion, which is a very important topic and is still contemporary. Dr. Alpesh, thanks for being with us.
Well, thank you for having me.
Yeah. So from the beginning, walk us through how to approach and calcified lesion, and what's your algorithm to modification?
Yeah, so remember, calcium is a very growing space. Almost 1/3 of our cases comes to the cath lab has some degree of calcium. So it's very important for our IC operators or even diagnostic angiographers to identify the severity of calcium. We sometimes forget that it gets missed, and it does not become a rotar regret as much as calcium regret. We have so many other modalities to fix calcium that detection is very important. And that goes to the next point of imaging, because imaging should be mandatory. I hope it does become mandatory one day, because if you can understand the plaque morphology, especially calcific lesions, your entire treatment algorithm will be different.
Absolutely. And do you have a preference for OCT versus IVUS, just to dive deep into the imaging?
I think OCT is probably a better tool when it comes to calcium definition. It is fantastic at understanding deep calcium, definitely much better than IVUS is. IVUS is limited in understanding deep calcium. But also for calcific nodule, OCT is better. That being said and done, the reality is IVUS is very easy to use, more people have experience with it, and for all practical purposes, in almost all the cases, IVUS suffices.
Exactly, yeah, because this is the bread and butter for every lab almost now.
Very true, very true.
So when we identify the calcium, and there is definitely different scoring system to see, when the operator should think of debulking?
Yeah, well, if you identify calcium which is at least moderate but definitely severe. So the definition of severe calcium is if you can see it on a still image, it is severely calcified vessel. Don't even think of anything other than calcium debulking. On imaging, if you have an arc which is more than 270 degrees, definitely debulk or do calcium modification therapy. But even if it is moderate to severe, more than 180 degrees, consider doing that as well.
Absolutely. And what is from your experience, now we have shockwave, we have orbital atherectomy, we have rotational atherectomy. The shelf is full now, which is good for us.
Yeah.
But which one you pull usually, and what lesion trigger which one?
We are very lucky right now. I think the fact that we have so many calcium modification therapy really allows us to do a good job, because ultimate goal has to be stent expansion and apposition. Yes. Because without that, we'll continue to do a bad job and never match up to surgical data. I think it's case by case. Just to give you a very, very basic perspective, if something has superficial, diffuse, concentric calcification, I lean towards a proper atherectomy devices, yeah, whether it's rotablator or CSI Diamondback. I don't personally have a big preference about it myself. Neither do we have any studies comparing those two. There are some small imaging studies, but they really don't show any major difference. So I think in terms of using one of the atherectomy devices, I don't have a preference, but if it is diffuse CAD, definitely use that first up. Yeah. Versus if you have an artery which has focal calcific lesions, eccentric, but also with some deep calcification, I think there is a role for shockwave up front, a little bit more. But then there are other devices too. We cannot forget Wolverine. I think it is kind of becoming like the aspirin of calcium therapies. Everybody is starting to forget about it. But it has tremendous job. It has done a very good job over years at creating micro dissections, controlled dissections in that calcified plaque.
Absolutely. Final question about, does calcium dictate duration of antiplatelet therapy? We just had a previous presenter or speaker talking about duration of antiplatelet.
Yeah.
Again, the setup ACS, no ACS, but has severe calcification. Does that change your?
Yeah. Not yet. I think there may be some data coming along the way, a little bit more. Yeah. Calcium, we do know that calcific lesions represents a lot of things. It represents a patient who's usually elderly. It represents a patient with chronic diffuse atherosclerotic burden. Plus, it also represents lesions which may not have been optimally stented in spite of your best efforts.
Exactly.
And that is that is literally a recipe for adverse outcomes, adverse higher MACE events, whether it is restenosis or whether it is even MI. So to that point, I think an argument can be made about favoring long-term antiplatelet therapy as we have come down to 6 months. I think it would be worth considering it for maybe 12 months or even 33 months if the patient is young enough or has low bleeding risk. But I don't think I can say that with scientific confidence that we should do that. We really don't have that much data to say that for sure.
Thank you so much, Dr. Shah. Really very insightful approach, step-by-step to calcified lesions. Watch these videos and others on our YouTube channel. This is Chadi Alraies from St. Louis. Thank you so much, Dr. Shah.
Thank you.